primary issue we're going to talk about, psychosis, is present in more than just schizophrenia. However, most of what we know about these things comes from schizophrenic patients that are diagnosed with schizophrenic and so forth. So I'll be heavily talking about schizophrenia, but you'll see there's going to be some points in here where I mentioned it happens in other disorders as well. So the learning objectives for this lecture, we're going to understand, really again, it all really has to do with the drugs, but understanding the basis for what we're going to call the dopamine hypothesis of schizophrenia will help you understand why we are using the drugs that we use today. So I want you to be able to understand that, understand sort of the progression of antipsychotic medications. We started first with the first generation of typical antipsychotics and then moved to atypicals, and give examples describing the mechanisms of actions like yesterday. Describe the mechanism of action, describe the mechanisms of their different side effects. Okay? So I want to start by talking about really, really fascinating and enlightening story, which has to do with this guy named Brian Charney. And Brian Charney was an art student. He was diagnosed as a schizophrenic. That was in the 70s. And what he decided to do was, in 1991, take himself off of his medication and then paint a series of almost daily self-portraits. Okay? And these, I'm going to show you these, they're not intended to be abstract art or any kind of bizarre representation. This is a legitimate self-portrait, like the one you see here. This was the very first one that he did in April of 1991. And he did a couple dozen of these over the course of a couple months. And so I picked a few of them out here. And you can see how the vision of himself and of reality deteriorated gradually as he took himself off the medication. And eventually, I think this one in June was his last one, and then he committed suicide less than a month later, a few weeks later. So this is kind of what we're talking about when we talk about schizophrenia. It's probably the most bizarre sort of psychiatric disorder that we can think of, because it involves dramatically altered perceptions of self and of reality. Okay.
Was the first photo you showed kind of his baseline while he was still on?
I think it was his first one after he stopped. Okay. So he was still relatively, again, like I talked about yesterday, these drugs are quite long acting, so it took a little time to wear off. So that was like a baseline, right?
He completely stopped taking all medication, beating himself down.
He just stopped turkey. So it's the disorder of schizophrenia, just some background information and that sort of thing. A chronic mental disorder affecting all aspects of behavior, thinking, and emotion, characterized by illogical, disconnected thinking and peculiar behavior, including a lot of social-based sort of behavior. When we talk about the word psychotic or psychoses, I'll define psychoses in a minute, but these are patients that experience delusions and hallucinations. Okay? People that have schizophrenia are not always delusional or not always hallucinating, but when they're in a state when they are, they're considered to be psychotic. It's a fairly high incidence worldwide, not anywhere near as high as what we saw for depression. Again, there's a fairly high, because you can imagine the stress of going through life like this, there's a fairly high rate of suicide attempts. So a little bit about the etiology, and I didn't really, I took out the slides on etiology yesterday because I wanted to focus on the drugs, but psychiatric disorders are generally thought to be some combination of genetic effects and exposure to unfavorable environmental circumstances. And schizophrenia is no exception to that. There's evidence for a number of different genetic linkages, but it doesn't explain the entire thing. There have been a number of different hypotheses as far as environmental factors that can increase sensitivity and trigger schizophrenia later in life or at that time. And interestingly, a lot of it you can see has to do with things that happen during pregnancy and around birth. Very interesting. In addition, things like stress, drug use perhaps, and there have been all kinds of other environmental factors related to social environments and things like that that have been posited to trigger schizophrenia in people. There's not really good evidence to point to one or two of these. Okay, so how do we diagnose someone with schizophrenia? So the DSM-5 says they have to have 2 or more of these characteristics for a significant portion of the time over 1 month. And again, like I said yesterday, it's with the depression, it has to come along with social and occupational dysfunctions. It's got to actually be having a negative impact on a person's life, and it can't be explained by some other kind of condition or medication. This is one of the new things that the DSM-5 added, this sort of qualifier. So the 5 symptoms are delusions, hallucinations, disorganized speech, disorganized or catatonic behavior, and then negative symptoms. So delusions, when we talk about delusions, these are what we call fixed false beliefs. So a delusion is something that somebody believes even though it can be proven obviously that it's false. So if I can remember the example, something like, things like the people on TV are angry with me, or they're playing songs on the radio that they know that I don't like and they're trying to upset me and things like that. As well as beliefs that you are a historical figure or something like that. Those are clearly things that are clearly false and can be proven to be false. Those are considered delusions, people having delusions. The other aspect that's important is negative symptoms, and these are sometimes called positive symptoms. We'll get to that more in a minute, but the other aspect is negative symptoms, which are things like affective flattening. So we talked about anhedonia yesterday, right? Well, anhedonia is inability to experience pleasure. Affective flattening is sort of everything is just sort of even keel. Good things don't make you happy, bad things don't make you sad, you don't get angry, you don't get upset. It's just all your affect is sort of just flattened and you're just even. Alogia, which has to do again with sort of speech problems. In this case, so this is usually what you see that's considered positive symptoms are like the person is like a jibber jabber, just lots of talking and it doesn't mean anything, it doesn't go anywhere. A lot of times, a good example of that is, you think of a lot of homeless people that just talk to themselves and things like that. You might have seen that. That's what they sort of think of as disorganized speech. Alogia is sort of like very short answers, inability to think of words, just not really engaged in a conversation. And then avolition is sort of just like decreased motivation to do anything. Okay. I'll let you guys read these. This is just basically says that there's a bunch of different subtypes of schizophrenia depending on which symptoms are more prominent. So catatonic is more motor sort of symptoms. The disorganized schizophrenia is with speech and behavior and so on and so forth. Paranoid, and then residual and undifferentiated. And then there's also sort of combinations of, like I talked about for bipolar, if you don't meet the criteria and so forth. If you also have depression, if you're also diagnosed with depression or bipolar disorder, it's called schizoaffective disorder. Schizophreniform disorder is basically you get a minor form of it, like we talked about cyclothymia with bipolar. Schizophreniform disorders, which means it's kind of like schizophrenia. And then there's also something called delusional disorder, if there are some mild hallucinations, but you don't have all the social and motor that go along with it. Okay, so one of the major things to understand about treatment of schizophrenia is, again, it breaks down into really 3 categories of symptoms. Positive symptoms, negative symptoms, and cognitive symptoms. So we talked about the negative symptoms. We talked about the cognitive symptoms. Those are the same that were in the top of the DSM-5 slide. And then there's also now, this is new, fairly new, is the appreciation that there's a 3rd category called cognitive symptoms. And this is just what you might expect. It's problems with working memory, problems with attention, social processing, so understanding cues in the environment. If you're in a certain mixed company, you might not use certain terms. You like telling a dirty joke among people that it's in a professional situation or something like that. And usually most of us can kind of take cues about what's going on, and so this is what we're talking about: disorder, cognitive disorder of social processing. So why is it important to talk about these different symptoms? So it turns out that the root cause of these differ, and as we'll talk about, they respond differently to pharmacotherapy. Also, their severity is not correlated, so somebody could have very, very bad positive symptoms and not that bad in negative symptoms, or vice versa. It does turn out that the negative symptoms are usually correlated with cognitive effects. So it's when people have that social withdrawal and that sort of thing, they also tend to have cognitive deficits. And what's important to know also is, a lot of these, especially, we talked again about anhedonia, right, with depression, social withdrawal, but this is separate from depression because antidepressant drugs don't mitigate these symptoms in somebody that has schizophrenia. Okay, so again, so that's all about schizophrenia, and we'll keep getting back to that. But what are we talking about when we talk about psychosis in general? So when we talk about a psychosis or a psychotic individual, so a psychosis is a distorted or non-existent sense of reality. So it's fairly broad. So we can be talking about a hallucination, like hearing voices speaking to you. We can talk about, again, delusions, which are fixed false beliefs, or even things that are sort of disorganized speech and behavior. So what that sort of means is, again, I think you think of sometimes homeless people that you might have seen, or if you've seen movies, like legitimate movies about schizophrenics, they will, sometimes constantly be in motion and doing things, and they look like they're working on something very hard, but they're really not doing anything. So that's what they mean by disorganized behavior, and then also speech. So here's the point that I sort of wanted to make at the beginning, is that these are common to a lot of psychiatric disorders, including schizophrenia, but also they show up in mood disorders, so depression and bipolar, people that have dementia or delirium, and then there's also something called substance-induced psychosis, so when certain drugs, especially things like PCP, what we call hallucinogenic drugs, induce that. Does anybody know the difference between dementia and delirium? So what do we think of when I think of dementia? What do you think of when I say dementia? Like Alzheimer's, right? Or age-related. So dementia is sort of a permanent situation. Delirium is like a temporary induction of dementia that can occur because of some medical issue. So things like, sometimes you get patients that get very dehydrated and they can become delirious. So it's like they have the same sort of symptoms that are similar to dementia, but dementia is a long-lasting, like permanent, basically, condition like Alzheimer's or something like that. And so also, in addition to schizophrenia, it can be caused by a bunch of other things. Trauma can induce psychoses, infections, and so on and so forth. Brain tumors, certain medications can, and drugs of abuse can. So, but again, the majority of what we know about psychoses and pharmacotherapy of psychoses comes from treating and studying schizophrenics. So that's the kind of the framework that most of this is in, and I'll talk a little. When there are things to say about some of these other things, I'll point that out as well. So the pathophysiology. So we know really very, very little about it, but hypothetically, when we're talking about these psychoses that occur with schizophrenia, it's because of overactivity of mesolimbic dopamine systems, so brain dopamine systems. And again, we'll talk about that in the hypothesis, When you see psychoses that are associated with delirium or dementia, it's thought to be more due to deficiency of cholinergic function. And again, this is really because a lot of the pathophysiology of Alzheimer's disease, which is where dementia shows up the most, or is most associated with, has to do with pathophysiology of cholinergic systems. So that's where that comes from. There's no other magic. There's no other, psychosis-related research that points to that. It's really because of, you see delirium, and also you see dementia, and also when you have delirium, it's also often comes with these conditions where there's cholinergic deficits as well. And then the other point is there is some evidence, possibly not necessarily through these systems, but it may be through indirectly through involvement of, for example, GABA and glutamatergic systems and their ideas about NMDA and metabotropic glutamated receptors as targets for medications as well. So very, very little that's really known about it. Okay, so we're going to talk about the dopamine hypothesis, and I'm sort of going to give you the sort of historical story like I did yesterday with the antidepressants, and how we came to understand what systems are controlling that. So the theory here again is that schizophrenia is due to an excess of dopamine activity in the brain. And this idea was based on two observations. First of all, we're going to talk about the drugs in a little bit, but drugs like chlorpromazine or thorazine, which was the first antipsychotic drug, were found to be potent dopamine, they found to work, and then later were found to be very potent dopamine receptor antagonists. So it leads you to think if that's what the drug's doing in the brain, the problem must be due to too much dopamine. It also turns out that drugs that boost dopamine function can cause a psychosis that's very similar to the psychoses in schizophrenia. So in normal individuals, there are sort of animal models of this as well. And so there you have the two sides of the coin there with that. So going back to some of the early evidence, and one of the initial studies that sort of provided a lot of support for this, I'm going to tell you about this technique called condition escape avoidance. So here's a picture of it right here from the original paper in 1957. And the experiment is very simple, okay? So you have a rat, and you see he's in his chamber, and the chamber has a grid, like a wire grid floor to which a current can be applied. And then there's this pole that's in the middle of it. And what happens is the rat is sitting down here, and then a shock is applied. And what happens is that you shock the floor, the rat jumps up and grabs onto the pole. Okay? That's called an escape. The shock begins and he escapes it. Okay? And in psychological terms, the shock is an unconditioned stimulus and the escape is an unconditioned response. Okay? Shock and they escape. Then the next thing that you do once you've trained that, which is it's not even really training, it's just a response condition. The next thing that you do is you turn on a noise for 30 seconds before the shock comes. And what do you think happens? The rat jumps when he hears the noise, right, and doesn't get shocked. That's called avoidance, okay? The rat's avoided the shock by jumping when he hears the buzzer, which is termed the conditioned stimulus, okay? So there's two different things here. There's escape and avoidance, two different behaviors. And so it turns out that they looked at a whole bunch of drugs, and what they saw was that certain drugs, so chlorpromazine, for example, that was a very effective antipsychotic drug, could block that the avoidance response without affecting the escape response. Okay, so what you see here is this is doses of chlorpromazine, and you see the percentage of block. So when there's very low dose of chlorpromazine, they will avoid almost every time. The buzzer starts, they jump. Buzzer starts, they jump. Buzzer starts, they jump. As you start giving higher and higher doses of this antipsychotic drug, buzzer starts, they just sit there, and then they get shocked when the shock comes. Buzzer starts, they just sit there, shocked when the shock comes. And so you might think, well, you're just making them so they can't jump, they can't move, something like that. But it turns out that it doesn't affect the unconditioned response. Okay, so the escape. So what happens is when you have this high dose, the buzzer goes, and they just sit there, and then when the shock comes, then they jump. So they can still jump, they can still avoid the situation, they can still escape the situation, but they stop avoiding it. And so, in the context of schizophrenia, now again, like what I said with the forced swim test, that doesn't mean that the animals have schizophrenia or something like that. But the thought was that what's going on here with this drug is it's blocking the ability of the animal to use this environmental cue that's coming in to direct its behavior and to jump and avoid the shock that's coming. Okay, so there's this sort of tie-in between that's what's wrong with schizophrenic people. They have problems with stimulating the environment. So that's really neither here nor there, but it turned out to be a really good model. and they looked at other drugs that seemed to be effective anxiolytics, and they saw the same, or effective antipsychotics, and they saw the same sort of thing. You can see here, though, you have, so this is barbitol, so this is like an anxiolytic drug. It's a precursor to the benzodiazepines, and you can see that really didn't do the same thing. You have a block of the unconditioned and a conditioned response. Interestingly, they tested morphine, and morphine looked just like these D2 antagonists. So it was a false positive in that assay, it turned out. But anyway, so there was some evidence that, so that really, again, pointed to was, this is a dopamine antagonist, which pointed to dopamine as being very important. And so then there's a couple other things I wanted to point out that were good evidence for using this model as a model of schizophrenia. So it turns out that if you look at, so here are 7 different drugs used in the model, and they looked at the ED50. You guys know what an ED50 is by now, right? So they looked at the ED50 of these drugs to compare which was the most and least potent. And so if you rank order these drugs in terms of potency, this trifluoroperazine was the most potent. And then you look at the average daily dose that's used clinically, the ranking is about the same. There's a couple of them are flip-flopped in there, but it's pretty close. So that was another good piece of evidence that the potency of drugs in this animal model was about the same as the potency of the drugs to treat the clinical condition. So that's good evidence that you have a good model. Again, it's really just a predictive model. Again, it doesn't mean that you can use this to study what schizophrenia is all about, but you can use this condition avoidance response model to study drugs. Another piece of evidence is that tolerance doesn't develop in either setting. So you guys know what tolerance is, pharmacologically speaking? Anybody define it? So when we talk about tolerance to a drug, it means that when you treat chronically with that drug, over time the effect of that same dose decreases, right? Another way to say it is that you need more of the drug over time to have the same effect. Okay, so tolerance develops. If tolerance develops to therapeutic effects of a drug, that's bad, because you need to keep ramping up the dose. Okay. If tolerance develops to side effects of a drug, that's good, because then over time the drug gets safer and safer. You don't need to ramp up the dose. So it turns out that these are this is a measure of side effects to. This is over a number of days of treatment. The number of patients that experience side effects to haloperidol, and this is an increasing regimen of haloperidol, which is one early antipsychotic drug. And you can see the longer you treat, the more and more people are getting side effects. So it looks like there is no tolerance developing to those side effects, right? Well, it turns out tolerance doesn't develop in the animal model either. So that's another good pharmacological parallel between the model and the clinical situation. So all this is just to say that it looks like that's a good model for testing and developing drugs that are going to be successfully treating schizophrenia. So that was pretty well understood, and one of the leaders in this area is a guy by the name of Phil Seaman, who looked at a bunch of different drugs, and if this doesn't convince you, nothing will. So this is a bunch of different drugs. These are all D2 receptor antagonists, every one of them. And what you see on this axis is their affinity for binding dopamine receptors. What you see on this axis is the average clinical dose, and the error bar is the range, the typical range that's used clinically. So the higher the affinity for D2 receptors, the lower dose is needed in treatment. So that's pretty strong evidence that dopamine is involved in schizophrenia. Remember, we're talking about the rationale and the basis for thinking that schizophrenia is due to an excess of dopamine. So that's pretty convincing. The other study that's pretty cool, if you remember yesterday I talked about the difficulty in studying actually the pathophysiological mechanisms of a disease in psychiatric patients because they've been medicated usually, right? And it's really hard to find adults with depression that have not tried any sort of medication. So it's hard to compare non-medicated controls to psychiatric patients because you have the compounded medication. So this was a study that was done by Dean Wong a long time ago, where he actually had, what you have here is, this is a PET imaging study where they're looking at D2 receptors in the brain, and you have three groups here. The first one are, N stands for normal, SN stands for naive schizophrenics, and then ST stands for treated schizophrenics. So you can see here that in this case, the treated schizophrenics and the normal or the non-treated schizophrenics are the same, and they're different from controls. So that suggests that this D2 difference is not due to medications, right? Because the medicated group is the same as the unmedicated group. And you see that they both have higher D2 than the normal individuals. Okay, so this is a rare opportunity or rare study when they actually were able to do this experiment.
Wait, so it's a disease of an overabundance of dopamine?
Yeah.
So wouldn't you think it would be decreased D2 receptors?
So actually the way that it goes is that, so when they take this measure, okay, so they put a radio tracer into the brain, and I'm starting this explanation without knowing if it's going to wind up to be right or backwards, but at least if you understand the explanation, then I can tell you at the end which one it is. So what you're looking at here is the amount of radioactivity that's coming from that brain area, right? And it's higher, right? So the amount of radioactivity there is determined by two things. Well, it's the amount of radioactivity that's bound to the D2 receptors, right? So there's, what you know is that there's more of the tracer bound in this group than in this group. So the reason that there's more bound in this group, there could be two reasons. One is there are more receptors, right? The other is there's less dopamine competing for the radio tracer at the receptor, and that's probably what's going on here, right? So yeah, so it's backwards. This doesn't really make sense, but basically what it shows is, so it could be an interaction of both of those. It's hard to say. But what it does show is that there's not a difference between the medicated and unmedicated. So whatever that is, it's not due to medications.
Yeah, I just thought that like schizophrenia was correlated to low D2 receptor counts, but.
Well, the idea is that, so the idea that I'm trying to put across here is that at the early days, because these dopamine antagonists worked, they thought that it must be that there's too much dopamine, right? But you're right, that would lead to a lower signal here. So I'm not sure, I'm gonna have to like look at that paper and figure out what their interpretation was. At any rate, there's some problems with thinking that it's all dopamine. Okay, so first of all, it turns out that the cognitive symptoms are more related in models and in human laboratory studies to decreases in dopamine function, not increases, particularly in the prefrontal cortex. And again, you saw from the dates on these things, this is like 50s, 60s, and 70s when people were thinking it's all too much dopamine. But we've gotten more sophisticated and so forth. The other issue is that, I told you that drugs that increase dopamine can create these psychoses that look like schizophrenia. Well, there are drugs that do other things that can induce this psychotic-like state, including drugs that are agonists at 5-HT2A receptors. And so your classic hallucinogens like LSD and DOI, DOM, drugs like that are all 5-HT2A agonists. And also drugs that are NMDA antagonists like ketamine at certain doses and phencyclidine or PCP are known to also induce hallucinations and psychoses. So, where do we stand right now? I mean, it's still, the field is still very focused on dopamine, but it's led to other avenues of exploration of possible, and we'll talk some more about that later, but other possible avenues of developing medications and other studies that are looking at different, specifically glutamate as a potential pathophysiological mechanism. Okay, so like I did yesterday, I want to kind of transfer now to talking about drugs, talking about treatment. And so, again, before 1950, what we were pretty much doing is locking people up in sanitariums, in fact, into the 1950s, locking people up in sanitariums and just making sure they didn't hurt themselves or hurt anybody else. again, in the 50s, you know, this is the same time that that the antidepressant drugs were starting to be developed. This French surgeon was looking at antihistamines as a potential sedative for use during surgery. And so Roland Poulenc, which is a French pharmaceutical company, asked them to try chlorpromazine, which again, like we talked about yesterday, was sort of another compound that came out in a series of compounds they were developing, looking at analogs of drugs that they knew were successful. And so Laborie tried this chlorpromazine, and it worked really well as a sedative. They became very sleepy, they lost interest in what was going on around them, and it helped prevent surgical shock. So they tried it in schizophrenics, and it worked. And by 1955, it was marketed in the U.S. as Thorazine. And this is just an instance of just an amazing, amazing revolution in that there was a huge drop in the percent or the resident population in mental institutions, because these people now didn't need to be locked away. They could be in, you know, raving mad and in the padded rooms and everything that you've seen in TV and the movies and so forth. They could manage their disorder with medication and go home and live with their families and so forth. And that's sort of shown in this graph right here. You can see, you know, in the 40s and 50s, and you know, think about what was going on in this time. These are a lot of people coming back from World War II and so forth that may have developed different psychiatric disorders because of their time in the military. And this is the number of patients that were hospitalized in thousands. This is about 500,000 patients in U.S. mental hospitals right here. And if you look at 1955, 56, when Thorazine came out, bam, it plummeted to less than half. And I should try to look up an even more recent figure, but you can see it just dropped precipitously. And so the first line of drugs that came out in the 50s are called typical or first-generation antipsychotics, and there are two different classes. One is the phenothiazines, like chlorpromazine. That was the very first drug that came out. And then the other class is the butyrophenones, and the flagship compound here was haloperidol or Haldol. So these are just basically two chemical classes based on structure, based on their chemical structure. So the phenothiazines, the butyrophenones, together they're called typical antipsychotics. Or I think the best name is first generation antipsychotics. They've also early on they were called major tranquilizers. And they're also, you'll still see them called neuroleptics. But these are really bad names. I think first generation is probably the best, and they're also called typicals. So what do we know about these drugs? So they all primarily block D2-like dopamine receptors. They can be taken orally, but they're also can be given as injectable or depot formulations if you have a highly agitated patient that you can't rely on to take their medication regularly. You know, very orally available. They're highly bound to plasma proteins. Like we talked about yesterday, they're very lipophilic, so they soak also into body fat, and they get released out of that very slowly, so they have a very protracted time course pharmacologically. The half-life is, you know, 2.5 days or so, and you can find metabolites in the patients months after treatment ends. They hang around a long, long time. So one thing about D2 antagonists, they're very sedating. They can be very sedating. And so, you know, really, if you think of it, a lot of what you're doing with these patients is just really sedating them. You know, you're not treating any underlying disease. You're just sedating them. If there's this overactivity that's causing all these symptoms, causing them to act out or whatever, causing them to have these psychoses, you're really just tuning that down and sedating them. And so it's often given at bedtime. These drugs have a really, really high therapeutic index, so it's nearly impossible to overdose on them. And again, I think that's in part due to the motor effects. If you took enough, before you could take enough of one of these drugs to actually kill yourself, your motor system would lock down. You wouldn't be able to take anymore. And that wouldn't have cardiac effects and things like that. There's tolerance to some of the antihistaminic and anticholinergic side effects, but not to the therapeutic effects. So that's good. So you don't need to keep ramping these doses up in individuals. Okay, so So how about the side effects? So, right, so when we talk about these drugs acting on D2 receptors and acting on brain dopamine systems, where are these receptors in the brain? So, this might be a review for some of you, but just in case, just to set the scene, we have two major dopamine systems in the brain. The mesolimbic, mesocortical system, and the nigrostriatal system. So the nigrostriatal system, these are dopamine neurons that have their cell bodies in the substantia nigra, and they project to basal ganglia areas like the caudate and putamen, and that's mostly involved in motor control, okay, voluntary motor control. And then you have your nigrostriatal system with cell bodies in the VTA, ventral tegmental area of the midbrain, and these project to the ventral striatum, like nucleus accumbens, and to cortical areas like the prefrontal cortex. And this is what's known as the brain's reward system and things like that. So these antipsychotics block all D2 receptors, typical antipsychotics. And when we say D2 receptor, the D2-like or D2 family, those are the D2, D3, and D4 subtypes. So it doesn't discriminate among those subtypes of the D2-like family, okay? So it's going to block all those. And so if I tell you that the major function of the nigrostriatal system is to control motor movements, what would you expect would be a major side effect of these typical antipsychotics? All kinds of motor problems, right? And so we call these extrapyramidal side effects, okay? So it means it's not just affecting the pyramidal neurons in the cortex that are supposedly controlling psychosis and things, but it sort of spills over into these other systems like the nigrostriatal systems. And so what you get, again, are all these motor effects. So you get akathisia, which is restlessness, tremors and spasms. You also get what's called dystonia, which are both involuntary movements and abnormal postures. And if you've ever seen anything about, seen any movies about schizophrenia or any TV, or if you just go to YouTube and look up something about schizophrenia, you'll see a lot of this sort of stuff. There's a condition called waxy flexibility, which is like you could take a patient and sort of move their arm, and then it'll just stay there when you let go, and they're just rigid and stuck in these weird positions. So those are some of the acute effects of high doses. The most serious problem is what's called tardive dyskinesia. And what happens is when you give these drugs chronically, you can imagine what happens when you give an antagonist chronically. You're going to get an upregulation of those D2 receptors, right? And so then they become super sensitive. And so any little bit of dopamine hits those receptors and turns them on. And so what you get is, sort of contrary to these sort of abnormal postures and rigidity, you get these very repetitive involuntary movements, particularly of the face and of the tongue. And it happens also in elderly patients quite a bit. So again, you could probably go and put tardive dyskinesia in YouTube or something like that, and you'll see they just kind of, even, they're doing a lot of this. And it's all totally involuntary. It's because of this overstimulation of these receptors that have been upregulated by chronic antagonist treatment. And there's some other there's some other side effects as well. There's endocrine effects, and there's some issues with body temperature. But really, the main issue with these drugs are these motor side effects, and it can reduce compliance as well. So, but nonetheless, this is what we had available into the 1990s. Until the development of the next line of antipsychotics, and these are called the atypical or second generation antipsychotics. And so really this started with a drug called clozapine in the 1970s. This was the first one of these to come along, and it wasn't a huge success for a reason we'll talk about in a little bit. There was still a lot of side effects associated with it. But then in the 90s, there was a huge burst of other drugs that came out, including some of these you might have heard of. Zyprexa or olanzapine really has got a ton of use, and also Seroquel or quetiapine is actually used a lot in the military. And so the difference between the atypicals and the typicals, the main difference, pharmacological difference, is shown over here. So these are pie charts and you probably can't see this very much, but it's the idea that's important. So there's a pie chart that shows the affinity at different receptor subtypes in the brain. Okay, so here you have haloperidol, your first generation antipsychotic, and the blue is D2 receptors. And actually, I think this is a little bit of an underestimate of what it's hitting at clinical doses. The blue piece should probably be a little bit bigger, cutting into a lot of this yellow. The yellow is alpha-1 adrenergic receptors. The green are serotonin receptors. And so what you can see is that these second generation or atypical antipsychotics have a lot less D2 activity and a lot more antagonist activity at other receptors. It has a varied profile, but what it has in common is it hits more receptors, they hit more receptors, and it's a lot less D2. And so, given what I just told you, what would you think about these drugs compared to the first generation as far as side effects? A lot less, at least a lot less motor side effects, right? And that's what turns out to be true. So with clozapine, however, there were some side effects, things like seizures and agranulocytosis, so some liver and blood problems that would occur that could be lethal. So that really limited use of clozapine in the 70s and the 80s. But these other atypicals that came out in the 90s are much safer. There's some, sometimes you see weight gain and things like that, but these are obviously things that can be managed. So if you're talking about a psychotic patient, it's either got to go in an institution or they can lead a relatively normal life and just have to manage their diet. You know, there's certainly a huge success. And this graph over here just shows an example of that. This is the percentage of patients without any kind of side effects, and you can just see that olanzapine, it's much higher over time. You know, even though side effects are coming on a lot, you see these, you know, these lines aren't up here with no side effects. There are some, but it's higher than perfenazine, which is a typical antipsychotic in there. So that's the major difference, and the main reason why these drugs are used a lot more. They're not much different though in treating positive symptoms. It turns out, in addition to being safer though, they're much better in treating the negative symptoms. So again, the negative symptoms, remember, are things like alogia, like impoverished speech, social withdrawal, things like that, a lack of movement. And so it could be because people aren't having these extrapyramidal side effects. So you can imagine, you know, I could make the argument that, well, a person with schizophrenia, they know that they have these extrapyramidal effects and they have these weird movements or things like that, so they don't want to go hang out in public. They stay by themselves, and that's why you see these negative effects, which is possible, and maybe that's why. It looks like the atypicals are actually treating the negative effects, when actually it's just that the atypicals don't have these side effects. So that's possible. But regardless of that, whatever the reason, they are better at treating the negative effects than these typical antipsychotics, which again are just kind of sedating. So if you have a drug that's a major sedative, that's not going to help if you have these sort of, you know, these sort of problems where you have decreases in behavior and things like that. Okay, so and you still have people that you have problems with compliance and people stop taking it. So here's just a list of some of the major drugs. I mean, the most important ones probably, you know, again, are the ones that I already showed you. Chlorpromazine and haloperidol were the first atypicals, and as far as I know, these are some others, but these are really the ones that dominated the market. And as far as atypicals, really quetiapine, olanzapine, risperidone, clozapine, and then aripiprazole we'll talk about more in a minute. Aripiprazole is one that you hear the most about now, and in a little bit I'll talk about why that is, but yeah. So to summarize, they're not really different in treating the positive symptoms. The atypicals are better at treating negative symptoms, and possibly also the cognitive symptoms, and for some reason, particularly in the elderly. The newer atypicals are much safer than the typicals in clozapine because you don't have the extrapyramidal side effects. There's also less risk of anhedonia and sort of mental cognitive effects which come from blocking D2 receptors. You have less sedation, less anticholinergic effects, less risk of cardiovascular problems, and those come from these drugs blocking norepinephrine receptors and potassium channels. But again, it's not like, these problems, cardiovascular anticholinergic effects, are not as prominent as they are with the tricyclics that I talked about yesterday. Because these drugs are fairly selective for D2 receptors, but with higher doses and longer treatment, you can start to see these things. So, as I say at the bottom here, essentially, the atypicals have replaced the typicals. They're still available for somebody to prescribe, but it's very, very rare that a physician is going to prescribe Haldol to somebody. I think they'll use it. I think the primary use of some of these typicals are things like in an emergency department. If somebody comes in ranting and raving and they need to sedate them really quickly, they'll give them something like Haldol to just shut them down so they can manage the injury or whatever's going on. But as far as a treatment for schizophrenia, they're not really used. Okay, so let's talk a little bit more about adverse effects and drug interactions and side effects and things like that. So there are side effects that are related to blocking the D2 receptors. Again, we talked about all these motor effects. We pretty much went over that. There are side effects related to blocking histamine receptors. That's thought to be the sedation, and that may have some involvement in the weight gain that occurs. There's anticholinergic effects related to the muscarinic receptor antagonism, and I listed them here, exactly the same thing as I told you guys yesterday, the dry mouth and so forth. And then there's also effects related to blocking alpha-1 receptors, orthostatic hypotension, like we talked about yesterday again with the tricyclics. So same sort of thing. These drugs do have some other activities that can bleed over in some patients, but like I said, like I just said, these are not as prominent with the antipsychotics as they are with the tricyclics, but it does occur.
And they're antagonists at the serotonin.
Yeah, most of all these are, most of it's all antagonism. So we'll get back to that though. That's why the aripiprazole is really interesting right now. Okay, so just a little bit more on these sorts of things. There's all kinds of different adverse effects that can happen. And I don't think you need to sit and memorize all of these, but the point is it's just a list of other things that can happen. There's metabolic effects. You can get all kinds of metabolic type effects. There are cardiac effects, seizures. There's this issue where patients with dementia tend to have a higher risk of mortality, and we don't really know why. These tend to be elderly patients. I'm not sure. I have a slide I think I have in here in a minute. As far as drug interactions, cigarette smoking will increase serum levels, and that has to do with, like I said yesterday, induction of the enzymes that, competition with the enzymes that metabolize them. And then we have, like I told you guys yesterday, antipsychotic drugs, the antidepressant drugs bind plasma proteins and then increase the levels of other drugs. So there is less evidence that antipsychotic drugs do that. Why that is, I'm not sure, but you tend to have less of that sort of side effects because of that mechanism than you do with antidepressant drugs. These are just a couple points out there. This is again something you don't need to memorize, but these drugs can be used in pediatric populations, so adolescents, including they're sometimes used in kids with autism that have these sorts of symptoms of acting out and being sort of socially disruptive and irritability. And adolescents, you know, as is typical with a lot of drugs, adolescents are more susceptible to some of these side effects than adults. And then they can be used in the geriatric populations, and they're more sensitive than younger adults. And interestingly, they can be used safely, it seems, in pregnant and lactating women. These drugs do cross the placenta, and they are present in milk, but don't seem to have adverse effects on the fetus. Okay, so these drugs are also used with anxiety disorders, particularly quetiapine is used quite a bit, and is being looked at for things like PTSD. Just some other examples here. GAD is generalized anxiety disorder, OCD, you guys know obsessive compulsive disorder. Tourette syndrome is another disorder that's very much understood to be based on D2 problems, D2 and motor problems. You know, major component of Tourette's is facial tics and things like that, involuntary movements. And so these drugs have been used to treat Tourette's syndrome, and have been tried for a lot of other sorts of diseases. Some of these have motor components. You know, Huntington's disease, the pathophysiology of Huntington's disease has nothing to do with dopamine, but because it's motor-based, people have, the symptoms are motor. People have tried dopaminergic drugs here, and there's not really a lot of evidence, but just know that these things are going, you know, they're very sedating. So when you have patients that have excess of anything, physicians have tried sort of D2 antagonism to sort of tune that down, often without a whole lot of success. Okay, so, this is a cool little segment here. And so having to do with going forward, what are new ideas in treatment? And so all the drugs that I've been talking about, for the most part, are antagonists, okay? So when we talk about what an antagonist is, if you guys have had, if I say intrinsic efficacy of a drug at a receptor, do you guys know what that is? Can anybody define what intrinsic efficacy is? Okay, I'm going to define it for you right now. So there's two parts to, and if you don't like this, it's your fault for taking a pharmacology class. This is pharmacology. There's two parts to a drug action, right? There's affinity, which is how well the drug does what? Binds to the receptor. And then there's the efficacy, intrinsic efficacy, which is how well the drug does what? No, turns on whatever the receptor does. Okay? How well it sort of turns on the receptor. How well it activates the second messenger systems, for example, that are associated with that receptor. Okay? So,
how's that different than efficacy? Is it the same thing?
so efficacy is a terrible word in pharmacology because it's used to mean a ton of different things. All right? You could talk about efficacy of a drug to produce a behavioral effect. People talk about that. So it's a difficult word. It's sort of a word like stress. Stress can mean 100 different things to 100 different people. But when we talk about the term of intrinsic efficacy of a drug in this context, we're talking about the second part. I'm sorry, I just knocked your phone up. We're talking about the second part of that, binding. So it binds the receptor and it turns it on, and it does something. It it's a G protein, so it does whatever it does. Okay, does that make sense to everybody? There's two parts to it. And those are not really related, right? So you can have a drug that binds a receptor really tightly, and then it doesn't do anything. And that's called a antagonist. Does zero efficacy. And so when you talk about intrinsic efficacy of a drug, an antagonist is a drug with zero efficacy. Okay? So it's helpful to think of it like that because then it's a continuum. All drugs are on a continuum. From zero efficacy, which is an antagonist, to the other end, which would be a full agonist. And generally we think of full agonist as being the endogenous ligand for a receptor. So in this case, D2 receptors talk about dopamine. Okay? So dopamine is a full agonist at dopamine receptors, and then you can compare the efficacy of all other drugs to dopamine. And there's this term called, if it falls in the middle between dopamine or between the full agonist and antagonist, if it falls in the middle somewhere, people call that a partial agonist. I hate that term, partial agonist, because a partial agonist could be anything that's this much less than dopamine to anything that's this much more than an antagonist, right? They're technically partial. They're in between that range. So it doesn't really help you to call a drug a partial agonist. It could be very, very similar, very close to a full agonist, or it could be almost effectively an antagonist that's called a partial agonist. I would rather, and when I talk about these things and write about these things, so we've done some studies with Larry Peppersol, and I call it a low efficacy agonist. In fact, it's a very, very low efficacy agonist. Okay? Or an intermediate agonist, or a high efficacy agonist, or a full agonist. So I like those 5 terms: antagonist, low, intermediate, high efficacy, or full agonist. Okay. So that's the idea, though. Think about intrinsic efficacy. So all the drugs that we've talked about so far, certainly the typicals, are antagonists. So they block, literally really block those receptors, bind the D2 receptors, and block them so dopamine can't do anything. And they themselves don't do anything turning on the receptor. Okay, and that's what leads to all these problems. So so that's why there's high excess of dopamine. People are having all these problems, these weird motor problems, and they're having these hallucinations. Shut down those dopamine receptors with an antagonist, all that stuff goes away. but you have all these side effects that develop. So the idea with a partial agonist, in this case aripiprazole, this low efficacy agonist, is, well, what if you mostly block those receptors, but you provide a little bit of stimulation to keep a little bit of that dopamine tone in the system, so it's not totally shut down. And so that's the idea of a partial agonist. And these are just sort of, I don't know how much these are going to be helpful, but so what we're looking at here is sort of, this would be like an in vitro type of assay, and you're looking at increasing concentration of whatever drugs we're going to give, and here's the response, okay? So the purple is dopamine alone. You give dopamine alone, and as you increase the concentration of dopamine, you get increased response up to the full 100% on your scale, which is, so it's considered the full agonist, right? So if you give, what they don't show on here is, if you give, say, Haldol alone, what you would get is a straight line at 0, right? You wouldn't get any effect, no matter how high you get. And that's the definition of an antagonist. Okay? Make sense? So what about if you combine an agonist like dopamine with an antagonist like haloperidol? Well, then you get this red line, right? So that, and what did he say, 100 nanomolar. So this is like the 100% effect of dopamine alone, and then you start dialing in the antagonist. What you get is eventually you can block all of that effect with the antagonist all the way down to 0, right? Which makes sense. And this is an in vitro assay, so if you give enough of the antagonist, you're going to occupy all the receptors in the assay, and there'll be no functional consequence, right? Okay, so now let's talk about a partial agonist like aripiprazole. Here you give aripiprazole alone, that's in the green. It's not a flat line at 0. It does have a little bit of an effect, but it doesn't get anywhere near the full effect. So this is a partial agonist, and in fact, it's a fairly low efficacy agonist. When we were doing these studies, I looked up every study that I could find that looked at, compared different D2 antagonists that had some kind of, or D2 drugs, agonists that had some kind of activity at the receptors, and aripiprazole was absolutely the lowest. So it's very, very low. And so what happens if you give dopamine, again, this 100% concentration of dopamine plus aripiprazole? Well, you get a block in the dopamine activity, but it doesn't go all the way down to 0. So essentially what you're getting here is you're blocking all the activity from dopamine, but you still have the activity from the aripiprazole. So you don't shut everything down. And so the idea is that this is going to be helpful, because what it's going to do is it will have a greater effect maybe in brain areas where you have more activity, or just overall you're not going to reduce the overall levels of activity all the way down to 0. Okay, does that make sense? And that's how you actually can tell whether something is an antagonist, actually how they typically tell whether a drug is an antagonist or a low efficacy agonist. So if you had, so aripiprazole, again, very, very low activity on its own. If you then give haloperidol with that, it'll take this down even farther. So the fact that you can see activity go down when you give a true antagonist tells you that that drug does have at least a little bit of activity and should be considered a partial or low efficacy agonist. Does that make sense? I don't want to lose you guys with too much of the details, but so keep it focused on the side effects of D2 drugs, and you can see that this should have a lot lower incidence of side effects, and in fact it tends to. So the occupancy that you need to produce these effects is much higher than other antipsychotic meds. So in other words, you would have to go to very, very high doses of aripiprazole to get the same kind of side effects as you get with lower doses of other antipsychotic drugs, which is good, because you don't need to go that high to get the therapeutic effects. Okay? Any questions about that? Why that would be, hypothetically at least, would be useful. And so you can also see how, so this might be a better drug. That's why, you know, the primary commercials that you see right now for Abilify are, ask your doctor, if you have depression, ask your doctor for this, as well as whatever antidepressant medication you're on. So this can help to manage some of those symptoms without being sedative and that sort of thing. Okay, other ideas that are out there. I mentioned glutamate as a major area of interest. There's also the idea, you know, which is sort of a continuation of the trend from the typicals to the atypicals of continuing to broaden out that profile, sort of similar to the idea that has transitioned from the SSRIs to the SNRIs. You know, we don't want to be so broad like the old school drugs that we have all these side effects coming all over the body from interacting with receptors in the cardiovascular system and all that. But maybe we need to not be too selective and broaden it a little bit. Idea is going on the same in development of these drugs. And there's others that are out there, but those haven't progressed very far. It's still very much dopamine based. And there's still, I don't think really anybody that would really argue that you can have a drug that has no activity at D2 receptors and still have an effective antipsychotic. It seems like you still need at least a little bit of that antagonism. Okay, so I have a little section here called Approaches to Treatment. And basically this kind of gets back into, so this is not about the drugs, but how we use the drugs a little bit. And I won't read through all this, but the point here is going back even before the 50s, what we used to do. You know, we were drilling holes in people's skulls and so forth like that. And then around the turn of the century and into the early part of the 20th century, the big technique that came through were lobotomies, right? And again, I know you all rushed out and saw One Flew Over the Cuckoo's Nest last night after my 5-star review, but there's also what happens to Jack Nicholson's character after the ECT is they eventually give him a lobotomy. And I won't take too much time. I'd rather let you go early than actually take time to go through this, but you guys can read through this. It's a really interesting history. And essentially, you know, what they wound up doing was just jamming a pick, ice pick, literally, into the person's eye socket and gouging out part of their brain in the frontal cortex, and that turned out to fix a lot of these problems, okay? And if it goes back to, if you know about Phineas Gage, goes back to that idea and so forth, that personality and that sort of thing is housed in the frontal cortex and so forth. Eventually, and then Moniz actually got the Nobel Prize for this in 1949. And so what I told you about the drugs, you see that was a huge revolution in treatment. And obviously there was a high mortality rate. And in 1967 actually was the last time this procedure was performed. And the patient died. But here's a picture. Anyway, this is really fascinating. If you're interested in psychiatry and interested in mental health treatment, you know, we're talking about, you know, 50 years ago, people were still doing this. This is how we treated people 50 years ago. Scooped out a section of their brain. That was the best treatment that we had. And so one of the things here that I have in this section is that sometimes you need to treat somebody short term, and sometimes long term. So short term would be in these situations where it's a transient sort of a state, like delirium, dementia, in major and bipolar depression or substance-induced depression, substance-induced psychoses. These are situations where it's not a main feature of the disorder, it's just something that's happening currently that needs to be managed briefly until it stops. So essentially what you want to do is decrease these symptoms that are causing either danger for the person or stress, distress. And so typically what happens here is that you know, you look at what the underlying disorder is, or the physician looks at the underlying disorder and decides what might be best for the person, which drug might be best for the person. Again, if it's a person's got cardiac problems, they might not use something that has a higher noradrenergic profile and so on and so forth. There's no way to really tell in these people what drug is going to be best. There's no biomarkers or anything like that. So in the case of delirium, in the case of delirium, it turns out that it's actually very dangerous. There's elderly patients have a much higher incidence of mortality so almost twice as high mortality when antipsychotic medications are used to manage delirium than younger adults. So it's a very odd thing. We don't really understand why. But typically what happens if you're a patient with dementia or you're in a situation of delirium is they'll use low doses just to control and sort of sedate you, control your behavior so that you don't hurt yourself or others. It turns out that drugs that have a high muscarinic cholinergic component actually worsen symptoms of delirium. And again, delirium tends to be associated with cholinergic sorts of conditions or disorders. There's other sort of side effects there. So the other thing, and so when I talk about bipolar, remember we talk about mania and these manic phases where people are kind of hypersocial, hypersexual, they think they can conquer the world. Often it gets to the point that it's psychotic behavior, okay? You know, they think they can fly and things like that, so it transitions from just kind of overactive to actually psychotic behavior. And so they, family member might grab them and bring them into the emergency department. And essentially, they will use any kind of antipsychotic medication there. High doses are used, and it's often continued after the manic episode ends in order to prevent it from recurring. Major depression, you don't see these psychoses very frequently in someone with major depression. It's more in the bipolar situation, so usually lower doses are used if that happens, and it's usually adjunctive to antidepressant treatment. Okay, so when we're talking about long-term treatment, that's somebody that has schizophrenia or schizoaffective disorder and needs to be maintained on these drugs. Relapse happens a lot, and so people that are being treated and supposedly on medication do have psychotic sort of relapses. But it's hard to say. A lot of times this happens because they stop taking their medication. And again, when we're talking about drugs that have all these motor side effects, you can see why compliance might be limited. So it's hard to say whether, you know, you're just always going to have these relapses of psychotic behavior in a schizophrenic individual, or it's that they stop taking their medication. And so in this case, it's really a focus on the side effects of the drugs and drug interactions, because they know that the person's going to have to be on these drugs for a long time. You know, again, just like any other treatment like these antidepressants, it might take a long time for maximal response to develop, and pretty much you follow the patient's progress and adjust the dose if necessary. You know, you will not be surprised to hear that the longer the patient is on these sorts of drugs, the greater risk of side effects. And so, for example, I told you there's a lot of metabolic effects, and in fact, schizophrenics have twice the prevalence of metabolic syndrome and type 2 diabetes compared to the general population. So that's not an accident. That has to do with treatment and side effects of treatment. So typically, the cardiovascular status has to be monitored, and they have to, you know, be vigilant for development of those sorts of complications. And I also wanted to point out here, there's a thing that pops up in the literature a lot called that is saying that an illness is called treatment resistant or treatment refractory, which is basically means nothing is working. And so it gets defined. It's defined as if you try 2 drugs for 6 weeks and then a 3rd drug at a high dose, and you don't get any positive outcomes, then that's considered treatment resistant or treatment refractory, and often they'll try ECT at that point. You might think, well, what if you just combine 2 antipsychotic drugs? Turns out that only makes it worse. So they don't really do that. Okay, so we'll take a few minutes and talk about some animal models of schizophrenia since we got a lot of time. So we already talked about the condition avoidance response. And again, I want you guys to be thinking sort of like my little rant yesterday about, you know, what are we modeling? Are we modeling schizophrenia? Are we modeling some symptom of schizophrenia? Or are we just looking at drugs? Are we looking at models that predict potentially clinically useful drugs? And the answer is the third one. And partly because a lot of things could be explaining behavior. So we talked about condition avoidance response. Open field behavior is often used, I shouldn't say often, it was used more frequently early on. And so, I don't know if you guys have seen something like this. This is, so a rat is placed in an open field, and this is like looking down at that field from the top, and it's divided in grid lines. And to measure the animal's locomotion, you can count the number of times they cross each of these grid lines. So a really active animal will have lots of crossings. An inactive animal will have very few crossings. And the other thing is you can do is use these tracking systems to tell where in the field the animal is at any given time. So that's kind of, you see this guy, he's kind of running all over the place. Sometimes he goes in the middle, sometimes he goes on the sides. This is an animal that's in a proposed sort of schizophrenic type of a state. And you see this guy just, he kind of hangs out in the corner and doesn't really go anywhere. So this is used, so you might expect that if you give a drug that's a good, that has potential as an antipsychotic, that you'd see more of this pattern. You take this animal and make it more like this pattern. Okay? A lot of problems with this. First of all, motor effects of the drugs. They get high enough, the animal's going to get catatonic, have motor problems, and not be able to move. And it looks, they may look like this anyway. Also, anybody who's done this open field work with rodents knows that it's also a measure of, it's also used very frequently to model what? What other psychiatric condition? It starts with an A. Anxiety, right. So the idea is that, rodents don't like to go out in the middle. It's dangerous, right? A hawk might swoop down and get them or something. So they tend not to go on the inside. So this might be really an anxiolytic type of profile. I have nothing to do with schizophrenia. So anyway, but sometimes that's used, not very frequently. Another model that's used, though, quite a bit is called pre-pulse inhibition. And this is a pretty cool model, actually. And so what it is a model of the deficits in sensory processing that occur in schizophrenics. Okay, so one part of what is thought to be going wrong in schizophrenics is being able to filter important information that's coming in from the world around you and focus. So an example would be if we were sitting here before class and you and I are having a conversation and everybody else is having their conversations and people are coming in and out and it's like, I would have a hard time focusing on what you're saying because of all this other stuff. I can't screen that out and focus, okay? So they call this sensory gating or sensory filtering. So pre-pulse inhibition is a model of that. So what it is it uses what's called a startle reflex. And the startle reflex is essentially an involuntary response to a loud or to a sudden stimulus, okay? So if I walk behind you and went like that, you'd probably jump. You might blink, you'd certainly at least blink. You might even flinch or jump or something like that. That's called the startle reflex. And so the way they study this in humans is eye blinking with like a puff of air to the eye and somebody will blink. The way that they do it in rodents is you can put the rat in a chamber where they're on a metal plate that has a pressure transducer that you can measure when they move. And so when you give like a loud noise, they'll jump and you can see that in the pressure on the plate. We actually do this in monkeys as well, where same sort of approach where they're sitting in a chair on a plate. We blow a puff of air to them or make a loud noise and they jump. And so the cool thing here is that this happens in basically, I think there's like 12 or 16 different species of animals that this has been detected in. So it's basically thought to occur in all mammals in one way or the other. Okay, so that's called the startle response. So it turns out that that response can be inhibited by some kind of stimulus that predicts it. So the way it's typically done, for example, in rodents, is it'll be a noise that startles them. And if you play a very soft noise that normally itself wouldn't produce a startle, play that right before the loud noise, the amount of startle is decreased quite a bit, okay? So that pre-pulse will inhibit the startle, pre-pulse inhibition of the startle, okay? And it's been studied very, very well. You can tell if you put the startle too early before the startle stimulus, if you put the pre-pulse too early, you don't get any inhibition. If it's too low, you don't get any inhibition. If it's too close to it, you don't get inhibition. It's been studied, the parameters have been worked out very well in all these species. So it turns out that this pre-pulse inhibition is reduced in patients that have a number of neuropsychiatric disorders, including schizophrenia. So basically, this is just a really simple diagram of what I just showed you. You give a loud pulse, you get a big startle response in normal individuals. If you give a really, really soft pulse, something more like half a second or so before the main pulse. Normal people, you'll get an inhibition of that startle. In a schizophrenic person, there's no inhibition that's startled. So again, you can see the schizophrenic can't use that pre-pulse to tell them that the big pulse is coming and you don't need to startle, that sort of thing. Okay? Yeah.
So is that supposed to be indicative of the lack of social cues in these people, or?
Yeah, I mean, it's just a basic inability of people to take in information in the environment and decide, probably less so with social, but and be able to focus on what's important and what's not right now. I think that's why the social is more under cognitive. The social is more that, the social sort of situation is, if I'm telling like really raunchy jokes or something like that and people are going, and I just keep going because I don't pick up on the fact that what I'm doing is really inappropriate. Not that that's ever happened to me. But, okay, so they don't show this inhibition. And so a lot of animal studies have done things like looked at the pharmacology of this, looked at whether drugs can influence this or not. But it's very, very cool because of the translational ability of it. You see these things in humans, so it's really a homologous model. We're not talking about, you know, I mean, this is the exact same thing that we see in human patients and in animal models. So there you're starting to get closer to a homologous model. So that if you understand the pharmacology of it in an animal model, you might be able to really know about the pharmacology of it in a human. Okay, some problems are, it turns out that these deficits are not sensitive to antipsychotic drugs, which is a little bit of a problem. The other issue is it's not specifically related to schizophrenia. It's also seen in other disorders. That's not really a huge problem, but it's clear that this is not, so it's not a model of schizophrenia. It's a model of some sort of deficit that's present in schizophrenia and other disorders that are similar to schizophrenia. So it's not a terrible thing. It just means that it's not really the whole end-all and be-all of the disorder, which is fine. Okay, another technique that's sometimes used is called latent inhibition. This is a little bit more complicated, but it's not too bad, so I'm going to explain it. So the idea is sort of conditioning. It has to do with pre-exposure. So let's say if I'm trying to condition some behavior like, think about Pavlov, right? Everybody knows Pavlov's experiment where he conditioned the animals to where if you ring a bell, they've associated that. So if he showed food to the dog, the dog would drool. Show food to the dog would drool. Then you start ringing a bell when this is classical conditioning. You ring a bell when you show them the food, drools. Ring a bell and show the food, then you can just ring the bell and they'll drool, right? That's simply classical conditioning. So in this context, in normal individuals, if, let's say before you ever started that experiment, you would ring a bell every day with no consequence for the dog, right? It'd be a lot more difficult to condition that bell to the food if they've got this pre-exposure to the food. Because now the bell means lots of things or nothing. And now it's harder to pair it with the food, than if they'd never heard the bell before. Now this is a novel stimulus, only present when the food is present, and you get that conditioning really well. So that ability for the pre-exposures to make the conditioning more difficult is called latent inhibition. Okay? Does that make sense? So that latent inhibition is decreased in schizophrenic individuals. Okay? So again, I mean, it's sort of like the stimulus that's going on, it should be weak, the conditioning should be weaker because they've heard it before, but that doesn't seem to matter. So again, it's a deficit in sort of taking the stimuli that they've been exposed to and associated with in the past and applying that to the current sort of situation. Okay, not really used all that much, but it kind of shows how that works. And again, some problems with thinking of this as a model of schizophrenia. In that the pharmacology of it isn't exactly the same as you see with the PPI, so you would think that if these are good models of the disorder, that would match up, but at any rate, it's been sometimes used. The other thing that's really interesting is models of negative symptoms. And so, we have models of anhedonia. There's lots of flaws with a lot of these, but we can develop models of anhedonia. A lot of these have to do with sucrose preference in rodents, for example, where normally with rodents, if you hang 2 bottles of drinking fluid in their cage and one is sweetened and one isn't, they'll drink more of the sweetened solution, they prefer it. And then you could do a number of manipulations that lead them to lose that preference. And so that's modeling somebody that no longer gets pleasure out of the things that are supposed to be pleasurable and preferred in life. Okay? A dependent variable, that choice, behavior that we use to model that. So a couple of problems, you know, again, like we talked about with the PPI and so forth, this is not unique to, anhedonia is not unique to schizophrenia. We talked about it yesterday with depression, and it's in another number of other psychiatric disorders. But again, that's okay. It's a major component of the disease, and a lot of sort of animal work has gone to the idea of, you know, we're modeling components of multiple disorders and saying we have a model of depression, we have a model of anxiety, we have a model of bipolar disorder. Okay. The other thing is that people are looking at is, especially in rats and mice, is sort of social withdrawal. Again, that's another negative symptom of schizophrenia, and it can be induced by things like amphetamine and PCP, which again we know sort of can produce psychoses and things. So that's sometimes used as to kind of generate this phenotype that can be used to study drugs and so forth. So, okay, any questions about any of that stuff? Feel free to call or email or stop by or whatever if you do. Other than that, again, I want you to know about the dopamine hypothesis of schizophrenia and how that transitions into why we have the drugs that we have today, right? How did we get from focusing on dopamine to developing these dopaminergic drugs? How do they work? What kind of side effects do we see with these different classes? How are they different across the classes? And so forth. Okay, no questions?